actually. So without further ado, I'd like to thank and welcome you to the session. My name is Giles Palmer, and it's a great honor to be co-moderating this session with such a great bunch of scientists, all experienced in modern lab management and of course quality management as well, and that's why we're here. There are many books on quality and ART, but often the practical aspect is missing. I mean, hopefully we're going to change that by having a sort of a dummy quality meeting. My co-host is Kelly Tilleman, Director of IVF at Ghent University Hospital. And Kelly, until recently, was a coordinator for the Special Interest Group on Safety and Quality in Art for ESHRA, which he did an outstanding job. We've also got Debbie Venier here, who's consulting embryologist at West, which is the World Embryology Skills and Training Centre. We've got Jeanette MacKenzie from New Zealand, the Scientific Director at Fertility Plus. There's also here a very favourite of ours on I3, Dr. Alison Campbell, the Group Director of Embryology of Care Fertility Group in the UK. And last but certainly not least, Dr. Tony Anderson, his Director of Embryology and Andrology and the Training Institute at embryodirector.com. All their contacts, all their details you can find on the website. But through this session, please ask a lot of questions, keep them busy using the Q&A section, but please feel free to chat away on that chat section. So over to you, Kelly.
Thanks, Giles. So we have a recorded a quality meeting from the members of Awesome IVF, and that's a group of people you may all just recognize. So tonight we have the part 1 of this meeting. We'll stop for a break and a few questions in the middle of the meeting, and then at the end we have a larger Q&A session. So as Giles explained, please chat away, and if you have questions, use the Q&A. This is fictitious and meant to be entertaining, right? So yes, quality management can be sexy. We will show you. So think how this would work in your clinic, right? What you learn, and bombard us with any question that you have. So in part 1, the session tonight, we have non-conformities, incidents and root cause analysis, document control audit. Then we'll have a break. Then we'll talk about new staff and training, regulatory and aspects and inspections, and some lab news from Denny, Sakkas. We will also have polls popping up for you to answer. So please be interactive during the meeting. So let's have and enter the quality meeting. It's just about to start. So I'll say, let's start the video. Thank you.
Welcome everybody to the monthly quality meeting by Awesome IVF. It's a time where all the staff get together and we'll go through what has happened over the past few weeks since the last meeting. All staff should attend so that they know what's happening in the clinic. We'll go over the details of the last meeting we had. We can welcome new staff. We can talk about matters which are arising in the clinic. Regulatory, we can look at and see that if there's any changes with our regulatory systems, we have to air that in front of everybody. We can look at difficult and interesting cases which have occurred or are due to occur in the clinic, which we should know about. It's a time when we look at complaints and even compliments as well in the clinic. Incidents obviously are discussed here as well as non-conformities and the corrective action which should be taken. Then of course any other business, anything interesting that all the staff should hear about, it's where it's aired in this quality meeting by Awesome IVF. And then to round it up, we look at any training that has to be done over the next month, and we'll pick a date for the next meeting. Everyone is here, I can see. You should have all received by email the minutes or the proceedings from the last Awesome IVF quality meeting, which was held exactly a month ago. You've all read that, I presume. And are there any omissions or mistakes or developments that we should know about from the last quality meeting?
I have got a development to report. At the last meeting, we talked about the breach of confidentiality that we needed to report to the relevant bodies. I'm pleased to say that they understand that it was a mistake. They are not actually grading the incident for us, but what they have asked us to do is put suitable things in place to make sure it doesn't happen again. And what we've decided to do is actually prevent our staff sending emails by mistake to people with similar email addresses by removing the automatic fill in the to box of your email. We're hoping that's going to help. We've also given additional training to our staff to make sure people are very, very careful, as they should be, when sending emails to patients and other members of the team.
Okay, great. So that's the closure of that event, and that'll be
Correct.
also suitably documented then as well.
It will be.
Okay, great. Thanks very much. Okay, moving on. Were there any incidents this month or any non-conformities that we have to know about?
Yes, I do want to report an incident that we had in the laboratory. We have completed an incident form, which I'd like to go through. I've got it on a slide to show everyone.
Great, thanks very much. If you could do that, that'd be brilliant.
So this incident relates to the use of consumables and media within the laboratory. Unfortunately, what happened was an embryologist was preparing for the next day's egg collections, but unfortunately, she found that there was not enough media in the fridge to cover all the patients on the following day. It was too late in the day for her to be able to order some more, and we had to resort to borrowing some media from another clinic nearby. We were really, really pleased that they were able to help her. They were able to help us, but obviously that's not a thing that we should be doing routinely. This did actually highlight some issues that we do have with regards to our SOP, and also it warranted an investigation into why this happened. As you can see, we did quite a thorough investigation. We looked at how we work out how much media we will need on a monthly basis, and therefore how much we needed to order. But also we looked at what we do in the case that we have an unusual number of egg collections in any particular month, which may lead to a similar issue happening again. So what we found was that in the month previous to the current date, there was more egg collections than usual, and therefore, because we had the usual number of bottles of media ordered, we didn't have enough to cover all of the activity. The second thing was that despite the media levels in the fridge being clearly lower than they should be, no one in the team took to be their issue, always leaving it for someone else to actually report it to the member of staff that does all the ordering. Obviously, that is something that we need to think about. And the second thing was, because the egg collection preparation was done very late in the day, much later than usual, there wasn't actually time for us to organise for additional media to be delivered to us that we could use. As I said, we were really lucky that we had someone nearby using the same media, and they were willing to share some with us. We will be replacing that as soon as we can. So with all these investigations, the important thing to do is to make sure that these things don't happen again. And so we look at corrective and preventative actions. I've come up with a few, which we're going to put in place very soon. This is obviously something we need to act on immediately. And the first thing is we're going to change the standing order level. So we have a little bit more media in the fridge at any time. We're also going to reorganize the fridge so that we can see very, very clearly when stock levels are running low. Importantly, to ensure that people take responsibility for the levels of media in the fridge, we're going to have a log sheet on the front of the fridge that people need to sign on a weekly basis to say that they've checked the amount of media we have available and that it's okay and suitable for the upcoming egg collections. And this will be signed and initialed. We're going to make a formal reciprocal arrangement with the clinic that helped us out. Hopefully we won't need to help them and we won't need their support again, but just in case. And also we're going to update our SOP to show that we're doing all these additional safeguards. These are all things that need to be actioned very quickly to ensure it doesn't happen again. Now, everyone needs to learn from this. All staff need to take responsibility for things that happen in their area. This may be losing, needing additional media, but in other areas, it may be other bits of equipment that are required. And also, we want to ensure that in the future, practice reflects these improvements. Does anyone have anything to say?
Well, I'll just say, I mean, apart from being obviously embarrassing, and it could have been a very serious incident if we went out of medium. I presume that medium in the neighbouring clinic was in fact compatible. It must have been the same
Yeah,
medium. Yes.
we were very lucky that they were actually using the same media as us, and that they had enough to share with us. So clearly they order more than they require on a monthly basis, which is obviously something we're going to start doing.
Great. And of course, when we have the new SOP, you will distribute that to all members of staff.
Yeah, we will circulate it, and everyone will have an opportunity to make any comments that they might have, or make any other suggestions that will improve our process.
Okay, well, thank you very much for that, Venessa. Thank you.
No problem. I know we're going to talk about root cause analysis in a future meeting, but I'll be quite keen to actually just take a few minutes to talk about corrective actions. This is a diagram to talk about problems. As you can see from this, often the problem is a much smaller thing than the actual root of the problem. What I mean is that quite often when you start investigating a non-conformance, you actually find there's lots of other underlying issues that need to be resolved. This root cause analysis ensures that in the future we won't make the same mistakes again. Now, people often identify reasons for a problem being related to staff being overworked, human error, but in fact, what we need to do is find ways to combat these issues, put in place SOPs that make sure those lack of staff do not cause a problem. We need to make sure people are trained and suitably motivated to take responsibility. Without a good team, things always go wrong. When we talk next time, we will talk a little bit more about how we can make these investigations a lot more straightforward. But what I do want you to remember is, firstly, the root cause analysis is only effective if you collect good information. To collect good information, you need to be a good communicator. You need to do good interviews with staff involved. And also you need to make sure that you have good knowledge of the whole situation. Human performance is related to many things. Training is one thing, experience is another. But ultimately, what we want to make sure is that we have protocols in place that protect our patients, our staff, and also ensure that the processes work really, really well. Again, as I said, we will talk about these at a later meeting.
Okay, that's great. So when people do deviate from SOPs, and obviously they do the investigations, they should perhaps think a little bit further, drill down, as you said, and we don't expect to see words like human error involved. We want to know why.
Exactly.
Yeah.
Human error is often used, and it's just such an easy thing to say. But in fact, if you have robust SOPs, there's no room for human error. Every single possibility related to the actual person doing the work has already been thought about. That's why when you do an SOP, you need to think about possible bad outcomes as well as the good ones.
Right. So obviously you get the reason that why was that error occurred? It could be staffing levels need to be looked at. It could be training had to be done, or it could just mean moving some furniture around the lab just to make it easier for someone to work. So it could be any one of those things, I presume.
But it could also be that the SOP isn't actually suitable for the process. It may be that the SOP is really old, it hasn't been reviewed properly, and actually practices have changed, situations have changed, number of patients, staff have changed. All these things need to be looked at. That's why SOP reviewing is really, really important.
Okay, that's excellent. Thank you very much. Thank you very much. So this month, no new SOPs to be circulated, but here's now just a few words about document control at Awesome IVF.
As you know, all documents at Awesome IVF, like a policy, strategy, SOP, contracts, audits, or even lab sheets, need to be kept relevant. We all have to sing from the same song sheet. Using the wrong version of a document is a non-conformity and can lead to serious adverse effects. So please, print them off only when they are being used. They are relevant only at the time of printing. As you know, each document has a displayed start date, review date, when it will be assessed, and of course the author's name. We will soon have a new central electronic archive and details coming shortly about training sessions, but please remember, Each new update will be deployed to you, the copy holders, to read and get familiar. Remember, if you see a mistake or feel the document needs to be updated, you can submit an electronic change request to the author. They are the ones responsible for generating content or updates. Again, if you see errors or if the document does not reflect current practice, then you will be able to submit a change request electronically. The document owner, for example, the lab manager in the case of embryology, or the chief physician in the case of medical protocols, has final say if it can be released and is responsible for its overall management through its lifetime. Unauthorized change can lead to different people doing different things, which can cause unnecessary complications. It is really easy to stay on top of this for the lifetime of the document, and any new SOP follows the same cycle: create, approve, distribute, review, and deem fit for purpose. Anyone impacted or expert can review. You can have scheduled reviews, or at any time the document can be improved and the new version 2, 3, 4, etc. be put into circulation. If any document is not fit for purpose, the document can be deactivated, so please tell us. And that is a brief glimpse into using our new electronic document control. Thank you.
So we'll now move on. The next topic, please.
Here at Awesome IVF, we think it's really important for staff to get involved in the audits. And it's part of our quality management system. And we have listed a whole range of audits that we think are really important to do as internal audits to check that our processes are working properly. And then we also have our required audits for our external inspections. So today at this meeting, I would like to present a re-audit of one that we audited in late 2020, which unfortunately we didn't reach 100%. So I'm just going to share the screen now to show you that one. So here we are. We had planned to do this audit in November, which we did, and this was to audit how the lab staff are adhering to practice according to standard operating procedures. And this particular audit was looking at blastocyst biopsy, and we wanted to make sure that all of the Awesome IVF embryo biopsy procedures are performed according to the written SOP. So the method of this audit was to determine our sample size, and in this audit it was to observe 10 embryo biopsy procedures, and I observed them myself, and the date range was for November, and the documentation that accompanied the audit was the Awesome IVF embryo biopsy SOP. So the findings of the audit in late 2020 were that 80% of the procedures observed during the auditing process were following the SOP as it's outlined in the laboratory manual. So that was obviously meaning that 2 of the procedures didn't follow the SOP exactly. So what we needed to do was find out why that we didn't get 100%. So we came up with some corrective and preventative actions in regards to this audit. We first of all had a lab team meeting to discuss the protocol, and we had a date for completion of the 30th of November, and then we filled in the date completed when we had done that action. Action B was to look at some extra training for the embryologist who was new to embryo biopsy. And I assigned myself to do that, and that was to be completed by the 1st of December in this box here. And we documented on the 1st of December that that had in fact taken place. And the last corrective and preventative action was to do a re-audit of this exact audit just to check that our corrective actions were working and improving the process. And we aimed to do the re-audit at the end of January 21. So that leads me to where we're up to today, which is the re-audit that we've just completed. So as I just said, the target date was for January, and again to check that embryo biopsy procedures were performed according to the written SOP. Again, we had a sample size of 10 procedures observed by myself. We had a date range of all biopsies, or the 10 biopsies done in January, and the documentation we worked with was the Awesome IVF embryo biopsy SOP. This time, when we observed the 10 procedures, 100% of these processes during the audit were following the SOP as it is outlined in the laboratory manual. So the conclusion now is that the Awesome IVF embryo biopsy is performed according to the written SOP. We've just recorded here the date of the report is the 18th of January. It has been reviewed by a senior and he signed it off here. And then the corrective and preventative actions for this one, we haven't put any immediate remediation on there, but what we do plan to do is re-audit as planned in the next 12-month period. And that has been signed off, an audit validation check on the 18th of January to show that the corrective and preventative actions from the original audit have all been completed, and now the procedure is being followed 100% to the SOP. So that's one of the audits that we've just done in the last couple of months. We just need to remember that upcoming mandatory audits we've got for our external inspection. So let me remind everybody that we've got the one coming up on data integrity of data submitted to the reporting body. We've also got our multiple birth audit. We've got an identification and traceability audit, and we've also got to audit the information on our website is in line with our reporting body requirements. So those will be presented at our next audit meeting. Thanks.
Thank you very much, Jeanette, for that. You mentioned some of the audits are like mandatory. Could you give us an example of sample size that we should be looking for?
Sure. So, for example, in the identification and traceability audit, which is going to be a paperwork audit looking into medical records, I would go for a sample size of 50 to get a good representation of the workload that we're doing in our Awesome IVF clinic. But it depends on the size of your clinic. If you're smaller or larger, you may need to adjust the sample size to get a good representative sample of the workload that you're doing.
Okay, thank you very much. That was the first half there, okay, of the meeting. Okay, I think it generally gives a picture of the meeting and how it's got to be. Kelly, how was that for you? Did that give you a good feeling about how some people do their quality meetings?
Well, very professional. I mean, indeed, questions are very relevant, and I think it's important that if staff members take on some quality management functions or activities, that indeed there is feedback so that they know if they did it well, and so that everybody learns from it. So yes, I don't only put QM tasks to my QM. I mean, I involve all of the staff as much as I can. So absolutely. Can I take a first question, Giles?
Of course you can. Of course you can. And
there was so the majority in the poll said that they were involved in document control, but there are some people who didn't know what document control actually was. So I don't know if one of our experts can have a brief explanation of what actually document control is and what is it not, probably.
That's a very good question to start off with. Who would like to answer that? How about Jeanette? Sorry, Tony?
Yeah. Well, document control is, as laboratory procedures are updated, you want to make sure that you have your previous procedure available for any expired or late procedures, but be able to manage those procedures along over time. I believe somebody asked if there's some digital versions of document control. One of the nice softwares I've used is Media Lab, You can put all your SOPs on there, and I believe there was, having the laboratory review all of those procedures. Once a new procedure is implemented, the entire laboratory needs to review that to make sure they're aware of the changes. And Media Lab is actually really good, where the whole lab can be digitally assigned to review that. And if they don't review it, it'll continue to remind them until they do. It's been a great software that I've used in the past.
Sure. And for me, document control is that, everyone is singing from the same hymn sheet. You can't have, someone, who's using version 2 of a document, okay, and another one who has probably printed out a piece of paper, several days or weeks ago, and is still using a different version. So it's just a way to control everything, every part of your document. And of course, there's a document owner, there's a copy holders that look at that, and it can be revised as many times as it wants. But of course, there are many companies that have these automatic document controls. You can do it manually, but there are, ones in the UK as well, which offer that procedure where when they're going out of date, when perhaps you have to review them, they will give you an alarm. Debbie, you've joined us now. How are you? You've joined us, but you're quiet. You're mute.
Sorry, I was late to the meeting. My apologies. I was doing a biopsy, so here I am.
Well, you're forgiven, and you snuck in quite nicely. In a short while, we will see one of your videos, and I would just like to say that this is a reenactment, so it's not important, the numbers in the documents and the numbers in the fields. I think it's actually the way that we are conducting these meetings. So as we go along, we shall have more polls and more questions. But is there anything, Alison, can you add something? People were saying about SOP should be flexible. I mean, is that the case? And how flexible can they be? Shouldn't they be followed by, word for word?
Well, I think if we're absolutely sure that we know what best practice looks like, then we don't need that flexibility. So if we have some professional guidelines which say make an assessment between this time window and this is evidence-based, then that's what we should do, and there's not really any flexibility there. There shouldn't be. But if we're talking about something like trophectoderm biopsy, then we don't know absolutely what intensity the laser should be, whether we should facilitate herniation of the trophectoderm by a breach on day 3 or day 4 or day 5 or not at all. So these things, I think it's important to have some flexibility so that we can then go back and look at the data and try and understand what is best. So both ways, really.
Sure, okay. But of course, an SOP is, is designed to be changed as, as the events fit. So I think it's time. Shall we start again for the next session before we start? Yeah. So let's play the second half of this, and please keep those chats coming, keep the questions coming, and we'll have a large Q&A at the end. So if Marianne can take it away for the next half of the meeting. Now for a staffing update.
All right, so we're going to give you a little bit of an update on some of the training we've been doing with our staff. Our embryologist, MB, started doing her ICSI training this December. So MB and I were focusing on trying to get her training completed by the end of December, and we made some good progress. How we managed it, because we're really busy the end of the year, we tried to really focus on late afternoons, dedicating some time to training. So she and I thawed 30 hamster eggs each day for 4 days. And then on the 5th day, we used all immature human eggs, and we practiced ICSI. We got a lot of injections in. So I just kind of wanted to go over her review and how we broke down her training. So the first thing we would go through was basic understanding of the microscope, being able to focus on using the high power and using her objectives properly. And she did really well on that. We did two days of training without a full evaluation. And then on the 16th, the 17th, and the 18th of December, I evaluated her each day to see how she progressed. So dish setup, she had been doing dishes for a while, so she was good at that, keeping them in the center and making sure they were covered in oil. Her pipette setup, which was very new for her, she progressed very well over the days. I think the only thing she really needed to work on here was her timing. I think when she tries to hurry, that's when we start getting some broken pipettes and the angles aren't set quite perfectly, but she does definitely understand orientation. She's aware of her space in the microscope, and she is able to align them and what I call thread the needle, which is where we actually put the ICSI needle right into the pipette so we know we're right on target. And she was really good at doing that. She just needs to work on speeding up a little bit. The third thing was her actual microscope use, using the oculars, using the objectives, and her spatial orientation. She did really well there. Then we went into the process of ICSI for sperm pickup. She was a natural at this. I know it looks like I was being really generous to her with 9s and 10s, but she was really a natural. She was able to immobilize them very easily, move them around it, and load them in the pipette super easily. So this was not a difficult thing for her. The egg injection, however, we had a few things that we need to work on. She was able to obviously inject the egg. She was very aware of being able to break the membrane when the membrane would break. She was super finicky on where the polar body was. So I was trying to explain to her, if it's at 12:30 or 11:30, it's okay. It doesn't need to be exactly at 12 o'clock, because she was spending a lot of time trying to get the polar body orientation just perfect. So we had to focus on not being super perfect with the polar body. We also had to focus a little bit on her. She had a little anxiety when the sperm would go into the egg. So pulling out a little too early, the sperm would barely be out of the ICSI pipette and she was pulling out a little quickly. So we need to work on that.
Dragging it back. Sometimes.
Yeah, sometimes pulling the sperm back into the funnel. So, but she definitely, by the 5th day of intensive training, we were training every afternoon for at least 3 or 4 hours. She was definitely staying late. So this was something she kind of had to make the determination to do. If she wants to be trained in ICSI, you're going to have to put in the time, and that might be overtime. So she definitely was dedicated in doing that. And a couple of nights, she was even here till 7 or 8 o'clock at night, practicing her ICSI and getting all those eggs injected. So it was good to see the determination, because I think that really makes a difference for how quickly you're going to get trained. So for the goals and the plan for the future for MB, we're going to plan on her setting up the pipettes regularly so she can increase her speed and efficiency in getting those set up. So regardless of whether we're doing an ICSI case or a biopsy case, and regardless of who's doing it, we're going to try to have MB, if she's available, set up the pipette so she can just get that practice and get really good at that. She's going to continue practicing injecting on all the lab microscopes. She does have a favorite microscope, and while that's kind of okay, it also can cause traffic jams in our lab sometimes when you only want to use one microscope. So we're going to have her practice injecting on all of the microscopes in the lab. And either the lab director or senior embryologist can monitor that and give her tips as she's practicing on immature eggs. She is now, after the training she's completed in December, she's ready to start injecting 2 to 4 mature eggs on cases that have more than 15 mature eggs. So regardless of who's doing the ICSI, if there's more than 15 mature eggs, we need to set a couple of eggs aside for MB to do ICSI on those. And then the plan for her is once she's done 20 mature eggs and she has a fertilization rate of at least 75% or better, we'll start splitting cases of 10 or more eggs with the lab director or the senior embryologist in the lab. And then we're going to closely monitor those fertilization rates. Once she's reached 100 eggs that have been injected with a fertilization rate of 75% or better, she'll be signed off for solo cases. So she's really excited about that. She's super enthusiastic. And our goal for this is to have this done by the end of first quarter. So we need everyone in the lab to kind of be on board and pay attention. If you have more than 15 eggs, you need to call MBN and have her do a couple eggs so that she can get those 100 eggs in by the end of the first quarter. And then I think Bill has some updates on some of the other staff.
Yep, so we do have a training embryologist, Ziggy, who just completed her vitrification warming training this past November. So she's doing great at that, doing that solo. We're going to start training in vitrification starting when we return for January of 2021. We're going to assign Jenna to focus on completing this training with Ziggy So we have to make sure in our daily schedule that training is slotted in for both Jenna and Ziggy to work on this. And our plan is to have Ziggy in the weekend schedule by February. She is already solo on egg retrievals and sperm preps, so she'll be a help once she gets vitrification under her belt. So February is our goal there. I don't think that's going to be an issue. Ziggy's been moving up the ladder pretty quickly, so we're looking forward to that. If you remember from last time, we had a tubing outlier, so we just wanted to give you a follow-up on this tech. So we had a no read rate for 2019 and Q1 and Q2 of 2020 of less than 0.5%. So, however, in Q3 of this year, we noticed an increase in that. So we kind of went back and actually contacted the genetic company first, since this was one of the newer ones that we're using, and they didn't see a difference with the other genetic companies that we looked at also. So then we broke it down to the embryologists and found an outlier there. So Tech A had a rate of 4.7%. So we were a little concerned about that. So we did some follow-up. And here was the process we used for this outlier. We had her observe, multiple senior embryologists and their tubing methods, and vice versa. So, and it seems that we did see a difference in techniques. So, and that difference was the placement of the biopsy in the tube itself. And it looked like Tech A was just not getting it far down to the bottom of the tube. She was just above the bottom, but this seemed to cause the no read.
I think that possibly was that it was drying up on the top and it wasn't spinning down.
Yeah.
So possibly was.
Yes. And so we retrained Tech A with 10 embryos that were donated to training. She biopsied, 30 different samples off these 10 embryos. We sent them to the genetic lab for DNA amplification. She had no problems there, 30 for 30. So we signed her off for solo work once again, and she's doing fine. And I believe that's it.
Did you have any questions?
Great, thank you. You mentioned this case of a new embryologist in the lab. I presume that you go through this competency either if they're new or experienced, or even if they're experienced from another lab and they're entering the awesome lab for the first time.
So for anyone new, once they're signed off to go solo, we monitor and check them every 6 months for their competency. Any senior embryologist past 2 years, they go through an annual competence, and everyone's up to date for 2020. Looking good.
Great. It's also interesting you mentioned about like favorite microscopes. I think that some embryologists from time to time do have the one which they're more comfortable on, especially if there's different models as well, isn't there?
Yeah. So I think for the new trainees, it's really important that you actually train them not to have a favorite. And if you train them, it's like training a dog to have new tricks. When they're young, they can learn, but us old fogies who are stuck on one scope, it's really hard for us to switch. But these young kids, if they're taught to use anything, they'll be able to use anything. So sure. I always make sure that they don't have a favorite. You have to be able to use any microscope.
Exactly. And you mentioned that, they can be like bottlenecks at some points as well, can't they?
Yeah.
Yes.
Yeah.
Great.
Because people will literally not start the next ICSI case because they're waiting for that person to get off their favorite microscope. Exactly. Instead of starting on the open microscope, they're like, no, I'm just going to wait. And then it starts to back up, and then the day gets gone and everything's not done.
Yep. So we'll now move on. The next topic, please.
Yes, I have something to add to discuss briefly here. This year we're going to be inspected. And so I want to talk about some of the things we need to do. And I'm going to base this on what I have done in other programs within the United States. There are several agencies that will inspect laboratories, and we're required to be inspected, but it's based on the model that was established to be compliant with CLIA, which is the Clinical Laboratory Improvement Act of 1988. In the US, programs also have to be inspected by the Food and Drug Administration. So what we're going to do, what I'd like you to be aware of, are things we need to do in order to meet any of these kinds of inspections by pretty much any agency. So what I'd like to do is have people think about the fact that we have to start in advance and we have to be ready for the inspection, and we cannot wait to do that the day before inspection. So we're going to start about 2 to 4 months prior to the inspection. I like to start earlier rather than later. Usually, entities that are going to inspect are going to send us information on what they want. It may be a checklist, it may be a narrative, it may be based on the law like it is in the United States for the FDA inspection. So it's up to us to make sure that we know what the checklists say, what the narratives say, what the law requires. So we're going to start by reviewing all of the paperwork from the inspecting agencies to see if anything is new. They are constantly updating checklists and narratives. Sometimes there are additions to the law. So we're required to be on top of what is currently out there. And so that's what I will be expecting from all the people on my team involved in doing the inspections. So the first thing I'm going to do is assign checklists to the various members of the team. So the andrology checklist will go to the andrologist. The embryology checklist will go to the embryologist. Chemistry is going to go to the endocrine lab. And then there will be general and all common based on the College of American Pathologists checklist. And I usually do that, but I'm very happy to share them. So we're going to review also in addition and in advance all QC and QA paperwork to make sure it's been updated. For example, we want all of our ranges to be accurate and we want everything that we measure to have a range, such as temperature. We want to have a range that reflects the use in our incubators or in our media. So we have to make sure that current usage reflects performance and it meets the requirements of the checklist. We're also going to make sure we review the FDA manual because that's part of the CAP checklist for us. So it's a good time and a good opportunity to review all protocol manuals. So we can make sure that we say what we do and do what we say. So we can't have protocols in there for something that we don't do anymore. And everything has to be reflective. So we are held accountable. If we say in our protocol that we're going to document something, we're held accountable for doing that documentation. So we want to make sure that we're not saying something that we don't do. We're going to verify all competencies for the staff, all training documentation, training competency assessments, 6-month competencies, annual competencies. Everything has to go in the personnel book. We have to verify all safety equipment, make sure that it's up to date, it's been inspected annually, it's been replaced. If it's defective, that everything's in good order, that our fire inspections have been done annually, that our eye washes have been tested, etc. So all of our safety equipment needs to be reviewed. And you can share the load here. This isn't one person that's expected to do this. We're going to do this as a group. We have to review all of our proficiency testing to make sure it's been, that the results have been reviewed, that all deficiencies have been addressed, that any of these strange little things that show up sometimes on our results, such as asterisks and question marks, have been addressed. They've all been corrected, justified, and the reports are all signed. We're going to verify all annual inspections of our equipment, our hoods, our incubators, our microscopes, our HVAC system, all the filters are current, all of our electrical has been inspected, our generator has been tested, and shown to be working appropriately, we have to have a list of every generator test, ideally every month, and make sure that that the generator has turned on and that all the equipment has come back on during the generator test and then after the generator's been turned off. And we're going to make sure that all of our servicing for all of this equipment has been done in a timely manner. All right, then it gets down. So that takes probably for my first inspection, we spent a good 8 or 9 months getting ready for the very first inspection. But then as you do this over years, it becomes easier and you have less work because there's fewer changes every month or every year. So the last week before inspection, we get down to some of the little nitty gritty physical things. We want to make sure we have all testing data from the manufacturers for all of our dishes. Our in-house mouse embryo or sperm survival testing has looked at everything that needs testing that didn't come tested from the manufacturer. As a team, we're going to sit down and go through all of our drawers and cupboards to make sure that everything is labeled, because inspectors have the right to go through every cupboard and every drawer and every refrigerator and every freezer. So we're also going to go through all our refrigerators and freezers. We're going to verify that nothing's expired, that everything's labeled appropriately, and that we don't have any unlabeled tubes or dishes or vials being held for any reason in a refrigerator or freezer. Nothing in those refrigerators and freezers should be unidentified. So the day before the inspection, usually inspectors come into the lab about 8 o'clock in the morning, and I don't like to have to get there at 6 in the morning to have to put everything out. So I want the room ready to roll by 8 o'clock the next morning, and I prefer to do it the day before. So I'm going to put out all the QC, the QA, safety manuals, FDA notebooks, and put them all in the room, in the conference room where we're going to meet. I'm going to put a tablet in the room that allows the inspector to access our media labs. Media labs is a program where we keep all of our procedures and policies. So we don't have notebooks for those. We don't keep a paper record. It's all online. And there's a way that we can give them a single day access to that, which we will do. And most importantly, we're going to order food and coffee and water for the inspectors. We want all that done by the end of the day before. Then the day of inspection, they usually show up around 8 o'clock. We're going to give them a tour through the labs. We're going to introduce them to all of the lab staff. Going to give them a demo of our proprietary database. We're then going to show them how to access Media Labs so they can get in for any of those checklist questions that they have to see documentation. They can get in there. And then generally, we're going to spend the rest of the day running around like crazy people, answering all their questions and finding documentation of everything they want to see. So what I actually like to do is have all the checklists filled out with little notes made on the checklist that says, this is where you're going to find the answer to this question. So we have everything planned out in advance. When it's all over, we're going to sit back and have a drink or two, possibly, to celebrate the fact that it's done for another 2 years, except for the after inspection paperwork. The inspector will always leave us paperwork for anything that they feel we didn't address. And usually you find inspectors come in and they really want to find at least one thing. So you have to address it. You have to do it in writing, and you have to have the paperwork to document it, because nothing is done until the paperwork is done. And then we're going to breathe a sigh of relief that we have another 20 months or so before we have to start this over again, because our inspections are going to be every 2 years. So we're going to have a busy year, folks.
Thank you very much. Is there anything that we should be particularly careful of in Awesome IVF, or things that we generally can overlook as a classic mistake, if you like?
A classic mistake? I think a classic mistake in these inspections is not to believe the inspection checklist. That it's like, oh, well, we don't really do that, so we don't have to do that. And no. If it says it, if it's on the checklist, you have to do it. or have a good justification for why you don't do it.
All our mandatory training sessions and all our competencies is electronically stored, so we can quickly, or the inspector can quickly have a look at that and see that we're all up to date. Yes.
Absolutely, absolutely. All our CMEs, competencies, all are in a personnel manual. Now, at big institutions, they usually keep things like, TB testing. We don't have to worry about that, but there are things that are specific to labs that we have to have, and training, competencies, CMEs, we have to have copies of diplomas. All of that has to be in the record and available for the inspector.
Okay, thank you. We've got a busy year then in Awesome IVF.
Yes, we do.
Okay, over to the lab now. Anything going on in the Awesome IVF laboratories?
This is what we're doing in the lab. One of the technologies we've always been interested in is looking at how to select the most viable embryo, and obviously that's probably the most critical part of being an embryologist, I think. But one of the things we've been interested in is comparing, do you use an invasive technique or a non-invasive technique? So to choose the best or the most viable embryo, you've got a number of choices, basically, or theories. Obviously, our tried and true one that the best or the most viable embryo has a different morphology or growth progression than a non-viable embryo. It's highly likely to be one that is euploid. So, we use technologies such as PGT. The best or most viable embryo also has thought to always have a different metabolic profile than a non-viable embryo. And also, the most viable embryo most likely has a different uptake or production profile of whatever, a protein, a metabolite, even DNA, than a non-viable embryo. And of course, there'll be other theories that will come along as we go along. Obviously, the technology we mostly use now in the lab is going for the best euploid embryo, basically, and that's done with an invasive technology where obviously you rupture the zona pellucida and you take a bit of the trophectoderm off the embryo. But we've been working on some new technologies that we feel quite promising, and they're mostly linked to looking at the metabolism of an embryo. And one of the technologies we've been looking at is a technology called non-invasive fluorescent lifetime imaging microscopy. And this measures two things in an embryo non-invasively. On the left is NADH, and on the right is FAD. If you look carefully at this video, you can see these are mouse embryos growing from one cell to blastocyst, but you can see on the left-hand side, the NADH is more fluorescent or more intense. It sort of goes away, and then the FAD fluorescence actually comes up in a brighter fashion. So what's really interesting about the FLIM microscopy, this type of fluorescence lifetime imaging microscopy, it just doesn't give us information on intensity. It actually gives us more information on the lifetime of the fluorescence, on the way the mitochondria are functioning. So we get actually much more information, and we can actually create algorithms or formulas to actually ascertain which embryo is the best one metabolically versus the one that's not. So this is great if you're looking at mouse embryos, but what are we doing with human? So these are human blastocysts, and you can see here we can actually take a scan of a human blastocyst. You can see on the left again here is the NADH, and on the right is the FAD, the same embryo. And you can see we can scan through the embryo and actually get information about the trophectoderm and the inner cell mass of blastocysts. So we've actually done quite a wide characterization of a lot of discarded human blastocysts. And the thing we're really excited about in the lab is we've seen a number of things. We've seen an incredible difference in a switch of metabolism when an embryo, a human blastocyst, goes from day 5 to day 6. So this is really fascinating. It indicates maybe which embryo is readying itself for implantation better than another one. We see dramatic differences in the way the metabolism is of an inner cell mass cell versus a trophectoderm cell. And what's really exciting is we think we can actually see patterns that might distinguish euploid from aneuploid blastocysts. So that's sort of what's going on in the lab at the moment for us. And I think, we're really keen on looking at some of these non-invasive technologies to save the embryologist from doing all this trophectoderm biopsies, and also, hopefully be able to non-invasively select which embryo is the most viable, or even euploid and aneuploid. So this is what's going on in our lab. Thanks.
Thank you very much for that update from the lab. You mentioned about the non-invasive. Now, of course, there are several non-invasive techniques that we're looking at. Can this be used in a combination with the others?
I think, Giles, that's what's going to happen in the future. We've got obviously time lapse, and there's amazing algorithms coming out from many labs now that it looks super promising. We've got technologies such as looking at factors in the culture media non-invasively, so at proteins, at metabolites, and of course at looking at DNA in the culture media to decipher whether an embryo is aneuploid or euploid. And then we have these types of non-invasive techniques. It's not just FLIM, this fluorescence lifetime imaging microscopy. There's other types of microscopy that, and again, maybe I didn't emphasize when I was saying it, but these are all non-invasive. You don't actually have to add any dyes or anything to the embryos. Some of these markers are actually markers that autofluoresce naturally in a cell, and NADH and FAD are actually luckily autofluoresce. So we don't add anything. So I think what will happen in the future is that we'll probably have algorithms that use the time-lapse information, possibly factor in DNA profiles, and also factor in metabolism, which will give us a much greater picture of what we just get now from just PGT alone. So it'll truly be able to tell us, a ranking of which embryos are the best for each patient. So I think all this information will probably come together using, I think, some sort of artificial intelligence, machine learning, to really truly tell us, which embryo is the most viable one out of a patient's, cohort of embryos.
Sure, and you mentioned that you don't have to have any additives, so it is completely like non-contact
exactly
research. And did I hear correctly that you said that different cell lines like trophectoderm and inner cell mass, they phosphoresce differently, perhaps?
It's incredible the difference between the inner cell mass and trophectoderm when we look at their metabolic activities are very, very different. And it's not really surprising. The trophectoderm's a much more buoyant cell. It's cleaving much faster than the inner cell mass. And, we know already that the inner cell mass and trophectoderm in the blastocysts have taken a different pathway differentially. So it's not surprising that's also reflected by their inert metabolism.
What about, have you looked at, like, you said day 5 and 6, what about like day 7? Have you had a chance to look at that yet? And also like cell repair, maybe I'm going off piste here, but cell repair with the trophectoderm?
No, I think we've only looked at a handful of day 7 blastocysts. So we really don't have any data, but definitely the difference between day 5 and day 6 is remarkable. And what's really interesting is that it's not really related to the embryo morphology. It seems like a timing factor. It seems like there's like a clock in the embryo that says, this is how you're going to behave metabolically day 5, but day 6, you're going to be doing this. And I think a lot of that is just to get the embryo ready for the implantation event. So it's, the biology of this is fascinating.
That's amazing. That's amazing. Well, obviously keep us up to date with that. That's fantastic.
Yeah.
Thanks. Okay, well, that concludes the first part of our awesome IVF quality meeting. I hope you enjoyed yourselves. We've had a lot of chat. We've got a lot of questions. We should really start with the Q&A. But before I start, there's a bit of, as I saw it written down, baked bribery going on with inspections. Has anyone, though, in COVID times actually done an inspection which has been completely remote? Because that is happening now, and I'm hearing it's quite productive.
I think in the UK, in the UK we've had a few desk-based inspections, so yeah, very different, but seemingly equally robust, I would say. Maybe the way forward.
Yes, and and the ones that I've heard, you'll have a set of things as you always do, but there's not that clamour to actually get the stuff done. There's time limits. Obviously, you have to get everything prepared. I think there's a question here saying you should always be inspection ready, but at least it takes the ordeal out that there's a set time. I think the people are going to be there and to be inspected. So, without further ado, we have a lot of questions. Kelly, do you want to kick us off?
Yes, I have a question that was handed in by Bronte Stone on document control. And so I think this person wants some information on the whole of the documents. I mean, we inevitably we are piling up documents, and bench demands on technicians grow, potential diminishing opportunities to verify compliance with expanding, multiplying SOPs, so SOPs. So how do we avoid the slippery slope of documenting compliance with in-house SOPs, even when we may not have, as opposed to maintaining the high ground where SOPs are targeted and concise? So, anyone has any tips for Bronte Stone?
I think the magic word is concise. I think if there's too much, then they're not user-friendly. It's more difficult to adhere to them. I think the future is a one-page visual SOP of the most important points. And then there's less deviation, there's more adherence, at least in theory. So we'll see. But I think sometimes if you've got 10 pages of words, it's not particularly helpful. So yeah, precise, concise.
Yeah, I agree. Anyone else has an idea how it works in their labs? Jeanette, Tony, Debbie?
I would agree with Alison. There's nothing I hate worse than going to inspect a lab that you're just so inundated with paperwork that it would take a week to get through it all. And in order to do a proper inspection, when if you just had it real nice and concise, it just makes it easier. So I think I saw somebody say, leave a little piece of rubbish around for the inspector to focus on, so it'll distract them from the actual inspection. But maybe that would be better than inundating them with a bunch of paperwork.
I mean, yeah. And we also have a comment from Noir Melly. I don't know if I'm saying it right, but of course flowcharts, and they can be incredibly descriptive, and it just takes the pain out of looking at so much paperwork. Concise is the issue as well. But I'd just like to add that, and I think as the question alluded to, that you can get drowned in paperwork, but there are a lot of electronic systems out there which do take away a lot of the fuss, and certainly you won't miss a thing if you do use these electronic systems for that. So any more questions about?
Yeah. I've got another idea. Like in your SOP, you can have it concise and quite generic, but then what you might want to do is next to your piece of equipment that might have specific instructions, you just have a work instruction beside the equipment that's specific to that. Might be a different ICSI microscope or something like that. Yeah.
Yeah, I think I've noticed sometimes it seems like people have way too much detail, like you must use this stripper tip size. And it really doesn't matter if you're using a 150 or 175 or a 200 sometimes, but their SOP says you must use this size stripper tip. Those details, I don't think are what's important in the SOP, but I think it sets you up for, you're not following the SOP if you're using a 150 instead of a 200. And there's certain details that can just be eliminated.
Yeah, absolutely. Thanks. Another question from Oksana, maybe Jeanette can answer this one. It's on in specialized audits like embryo biopsy. I like to involve many people from the whole of the fertility center in internal audits, but what is your opinion on specialized audits like embryo biopsy? Yeah. Does it really need to be an embryologist, or can somebody else do it too? What's your opinion?
Yeah. Hi, Oksana. Nice to have a question from you. I think for something quite technical like an embryo biopsy, it's going to be very useful to have an embryologist or someone that knows what's going on do an audit on that process. So you'll have to choose who is the most appropriate person to do the audit
there'll be some audits that are laboratory based, but anybody could do. If it's a paper-based exercise, they can learn about what documentation is supposed to be recorded where. So, but I agree with the specialized laboratory technique. It really, I think it needs to be someone that knows what's going on.
And of course, audit is a tremendous learning tool. You could have a pair, one who's lab-based and one who's not, just to see, you can get accustomed to the EMR, you can get accustomed to where all the data is. So again, any audit can be a an amazing tool. I've got a question here. It's from Lisa Nelson. When hiring a new senior embryologist, what do you do to document initial training when hired? How much training is required for initial training of a highly experienced embryologist? So again, someone going into the lab for the first time into that lab, but of course is highly experienced. So, what kind of competency would you suggest is needed to be done? And that's of course everybody.
So I do a lot of per diem work where I go and have them competency assess me before I start per diem work, and I call it see one, do one. So I watch them do one, and then I have them watch me do one, and then we sign off. See one, do one. For a fully senior person who's been in the field for years, see one, do one.
Right. Well,
we would have personalized training and induction, I would say. So we get a new senior embryologist. I want to know what their experience level is. I want to see their competency plans and assessments from where they've come from, and then schedule a program that's just right for them, which can be fluid. So if we've planned to do 5 observations of them performing an ICSI and they do 2 or 3 and they're immaculate, then that's enough. So we need flexibility, I think, and personalization when someone arrives with a lot of experience.
Thanks. Another question by David Wax. Any recommendations for very small labs? I mean, it's very nice. We probably all have quite huge numbers of staff or medium number of sizes of labs, but what if you only have 1 embryologist and 1 andrologist? What about training there? And also, what about risks there? Anyone wants to take this one?
Yep, I'll throw in some comments. When I think, there are minimum recommendations regardless of how many cases you have. I think with up to 150, you should have a minimum of 2 embryologists. I believe that's what ASRM recommends here, and 1 andrologist. And then one of the things a lot of people don't recognize is that if you have an endocrine lab as well, I prefer to cross-train people through each lab so that in the event of a busy day, people can support each other. As Bill and Debbie pointed out, if they can do a sperm prep or a vitrification, cross-training actually is very helpful in a small lab where you just have limited staff. Unfortunately, a lot of labs don't run like that. You have 1 embryologist, 1 andrologist, but if you do have set up systems where, maybe you don't need to have a fully trained embryologist to do your witnessing, and, making sure you have processes in place for that in those smaller labs.
Thanks, Tony. And indeed, we are going to talk about staffing a lot more next week. So, Giles, you see any more questions you want to share?
Well, I was just going to continue the question a little bit and talk about about lone working and what provisions should be done there. Jeanette, I know that we've worked together in the past, and what's your opinion about witnessing and weekend work? How would you deal with that?
So, of course, the regulation is going to depend on what country you're working in, but I am, as you know, a big fan of electronic witnessing. So I think if you're in a lab where the situation is that there is only 1 embryologist and 1 andrologist, you're going to be in a high risk situation. So you want to carefully consider whether electronic witnessing, and there's a few different types out there available, is something that you want to invest in to lower your risk. You can also do other kinds of risk assessments if you don't have electronic witnessing, about spacing the workload out during the day and having it clearly planned and documented about what procedure is happening at each time to show that you've only got one sperm sample in the lab at that time, or you're only doing one procedure at one time. So there's different approaches you can take there.
Okay. We've got some tricky questions coming up. Okay, there's some very easy ones we've got on the list coming up as well, but here's one from Brian Woodward. If we have one senior embryologist only, how do you audit them? It can be intimidating for a junior to audit a senior. That's what's written down here, especially if they see faults. So is there any advice? Can anyone give any advice for that?
I could try. I'm not actually convinced that to audit an embryologist, you need to be an embryologist. I think if you go into audit for the purpose of troubleshooting, then yes, you need to know precisely what you're looking at. But if you're just auditing practice against a document, an SOP, then you perhaps don't need to be an expert. You just need to make sure they're following the steps and it makes sense. And there could be advantages in doing it that way. So in Brian's scenario, you could involve a different member of staff to participate in the audit. And in the case of having just one embryologist and one andrologist, which, as I think we agree, it's not ideal, but some clinics find themselves in that predicament, then contingency planning and support networks with other clinics nearby would be essential. And you know, these poor lone scientists will need some time off from time to time, I'm sure. So in terms of being intimidated, that's always going to be a challenge. It's going to be dependent on personalities. So very transparent culture, great quality management system should minimize the risk of those scenarios, I would say.
Yeah, and if I can add to that, Alison, I think that for a senior embryologist, I would actually ask a senior medical doctor to do an audit. I mean, that would be very interesting, or even your responsible person, so that connection gets a bit tighter. So there's a lot of opportunities still there if you look outside the group of your embryologists. Jeanette, did somebody else wanted to share something else?
Can I add something?
Yeah.
One of the things that I think is important is, I'm sorry, 4 people just walked into my lab and I lost my train of thought, is that we don't really call it an audit. I call it more of let's watch each other and make sure that we haven't drifted in our protocols. So, you know, again, you're right on the personalities. You have to have the right senior personality where they can kind of come down and say to a junior, why don't you watch me and see what I'm doing different than you? Has one of us drifted in our protocol? And we kind of watch each other, and we're all on the same level type of thing, regardless of how many years you've been an embryologist. We all want to make sure that we're doing things the same. And that's kind of the goal of a lot of that. And so we don't really use that fancy, scary word audit. It's like, let's just make sure we're still doing things the same. Let's watch each other. And what do you notice different? And I use, when I'm training someone in a new lab, I use them as my auditor for everything. So have everyone in the lab teach you how to do something and then tell me what was different. So it's that brand new person that walks into the lab that is the one that usually picks up the differences between the embryologists. Because one embryologist says, I use this device and I do it with this dish. And they're like, oh, well, they use different dishes, different media. And everyone's like, what? You know, we didn't even know that happened. So it's usually the junior person that's picking that up.
Yeah, and setting up minimal threshold limits for everybody to hold everybody accountable to the same measuring stick. So it could be anybody from the office, as Alison was saying. It doesn't have to be a senior level person, or as Kelly was saying, you know, a senior level physician would be, you know, somebody that they're looking up to. I would say that it would be challenging that if you had somebody, there's always personality conflicts in every center. You'd hate to have somebody doing a competency assessment of somebody, maybe they didn't really care for them on a personal level, so they give them a bad score, which is like, I like to have, you know, more senior level people do that it's usually my lab supervisor or myself even. When I'm available, even if I'm doing offsite work, I like to evaluate people's competencies.
Yeah.
And of course, an audit is not, a blaming exercise. And although we did put this audit into this quality management meeting, and we had a question actually on the Q&A, it was like, shouldn't the audits be in a separate meeting? Well, I think we could all agree that they should be, but sometimes when there's a re-audit, they can, of course, that can be aired. And what is important is for people to see the actual corrective actions as well, I think.
And then, Giles, just to add, we say we're going to do our corrective and preventative actions. You need to go back in a couple of months' time and actually check that you've done everything on your list that you said you were going to do, to just close the whole loop.
Yeah,
sure. Yeah. We're nearly time to close a little bit. We've still got to show the clip, a little trailer of the next session we've got. But are there any questions you can see on the Q&A section that sort of like jump out at you, which you want to answer before we start to round up? Are there anything there we can see? One question is, how often should these quality management meetings be? Would anyone like to comment on that?
We usually do quarterly. Some people do monthly, and then there's usually an annual one that's very detailed and in depth. It's reviewing every detail, all your stats, all of your incident reports for the year and everything. So the annual one is very in depth and very long, and everybody's involved. And then quarterly one is a little bit more quarterly involved, and then there's just lighter, more monthly, more like lab meetings where you're just touching on the more simple stuff.
Sure. Anyone else?
Well, I know that CAP requires at least one a year. So one quarterly management review of your year. And as Debbie said, looking over your stats, and typically that would be considered like your quality management review. That's the minimum. I think you should do more often than that, but I like the quarterly plan myself personally too.
Yeah, it's a fine balance between obviously too many meetings and of course piling it all in. And it depends if you have your own quality lead who is separate from the actual lab staff.
If you have a good EMR that gives you data quickly, it's nice to be able to look at that as a litmus test, like when things are slipping maybe a little faster. And I do know of some lab directors that they can look at their fertilization rates and their blast conversion rates and their cryopreservation rates instantly, weekly. They don't meet on them every week, but at least they look at them and maybe be able to catch things earlier and decide maybe they need to meet earlier.
Sure. Well, that'll be one of the topics in the second part of this. We're talking about KPIs. Tony, yourself, you'll be doing about validation. And of course, we're doing other things which we have in the quality meeting. So just stay for the fun clip at the end. But I'd just like to thank everybody in our closing who took part in the recordings of this awesome IVF, but also tonight. That's Dr. Kelly Tilleman, Dr. Alison Campbell, hey, have a wave. Jeanette MacKenzie, thank you for getting up so early. Debbie Venier and Dr. Tony Anderson. So thank you all very much for that. And thanks to the organizing committee, of course, that's Jacques Cohen, Peter Nage, Thomas Elliott, Marianne Chevetes, and of course, Shaista Sadruddin. And they were joined today by our Q&A ACE team, which was Dara Berger and Anna McLaughlin. So thank you all for that. Over to you, Kelly.
Yes, and for all of you, the next session will be on the 13th of July with About Time, which will be all about the profession of embryology with the emphasis on workload and staffing. So there were already some questions here tonight, but we'll go more into detail on that meeting. And we will leave you with a preview of part 2 of An Awesome IVF. And this is coming up. So we'll leave you with this great taster, and have a great night, morning, day, wherever you are. And thank you. Goodbye.
Now moving on to the premises.
Hi, Chairman. I would
Fill me
like
the
to
sound there,
discuss
please.
about the recent renovation that we have done in the facility.
Okay, moving on. Any interesting cases?
Marianne,
can we have the
anyone
sound
from
the group want to discuss anything?
Yeah, well, I did want to address the group. There is an interesting finding that I've stumbled upon.
From the lab, Tony?
The product is called Device. You can tell from the picture. It's actually a state-of-the-art chip used, that can be used in
our embryologist KPI-based competences as we do
Right,
per
so
quarter.
here we have the results, our monthly report. As usual, we'll look over the matrix. So it's the KPI matrix for our clinic, our awesome IVF
Okay, so we
clinic.
have no complaints this month, which is really reassuring. Looking at the numbers, we are lower than last year in respect to complaints. And just a quick reminder of findings from last
are coming up. So I want everybody to remember that we are all going to be attending the Breaking Bad News Masterclass. So this is, it is always challenging to break bad news. And this class, I think, will make you feel more comfortable and learn some really helpful tips
Thank you very
in how to
much.
do that.
I think it's time to conclude our quality meeting. Thanks for the topics that everyone has brought to the table. I'll have a date shortly for next month's quality meeting, but until then, goodbye and stay safe. Thank you.